you can log in by about 8:30, 8:45 is okay, ma'am.
Sure. Thanks.
Yes, ma'am.
We are live, ma'am.
All right. So, good evening, one and all. On behalf of the Indian Thyroid Society, it gives me immense pleasure to welcome all of you to another edition of the ITS Thyroid Clinics, the webinar series. So these, in fact, clinics have become very important platform where we discuss very numerous cases, numerous dilemmas, and also recent advances in thyroidology. So the clinicians and also the trainees in the field of endocrinology can learn from across the experts in the country. So before we begin today's session, let us watch a brief video of the Indian Thyroid Society highlighting the society's mission, the ongoing initiatives, and the impact to create awareness on thyroid health across our nation.
तस्य भासते सर्वमिदं विभाति।
So before we begin, I would like to acknowledge the leadership and the team of the Indian Thyroid Society for continuously supporting us through these academic initiatives. So the Thyroid Clinics is currently being conducted under the leadership of Dr. Pramila Kalra, who is the President-elect, and Dr. Roma Pradhan, who is the EC member. So we have also Dr. Narendra Kotwal sir, who is the President of ITS, Dr. Arun Menon sir, who is the Secretary, and Dr. Mini Madam, who is the Treasurer, always guiding us. We also have Dr. Chitra Madam, Dr. Vijay Reddy sir as part of the Thyroid Clinics. So a short announcement before we proceed further. Those who are interested to submit the journal to the flagship journal, that is Thyroid Research and Practice, can do so by scanning the QR code displayed on the screen. And those who are interested to become reviewer for the Thyroid Research and Practice can do so by scanning the QR code. So this will help you sign up as a reviewer. And another announcement we would want to make, that is those who have won the quiz in the previous sessions and have not received the certificate can mail us on my email ID or Dr. Pramila's email ID or the technical support team of the ITS. So that will be displayed at the end of the session. So moving ahead with today's program's overview, tech team, can I request you to please display the today's program details? Yeah. So today's program details will have a case presentation presented by Dr. Naveen Kannur, a DNB resident in the Department of Endocrinology at NH Bangalore. This case discussion will be moderated by the distinguished faculty Dr. Subramaniam Kannan sir from Bengaluru and Dr. Aishwarya Krishnamurthy from Ghaziabad, UP. Then we'll have an insightful presentation on the management of thyroid nodules by thermal ablation by Dr. Siddharth Chakravarti from Hyderabad, Telangana, and followed by quiz by Dr. Chandana from Hyderabad at about 8:50 p.m. So moving on, I'd like to introduce the moderators for the case discussion. So we have two dynamic moderators. So Dr. Subramaniam Kannan sir, who is the Senior Consultant and Director of the Department of Endocrinology at Narayana Health, Bangalore. Sir has received numerous awards to his credit. So some of the major awards include the ESI Multicentric Grant for the management of thyroid nodule assessment, and also artificial intelligence integrated molecular cytology for triaging thyroid nodules, and numerous publications also sir has received, has to his credit, like the active surveillance of papillary thyroid cancer and the utility of next generation sequencing and the management of thyroid nodules. So can we have, the next moderator is Dr. Aishwarya Krishnamurthy, who is a senior consultant and head at the Department of Endocrinology at Max Super Speciality Hospital at Vaishali, Ghaziabad, UP. So she has also numerous achievements to her credit, including publications of about 18 indexed and awards, being the gold medal award for the best thesis in MD General Medicine in 2013, and also has been a speaker in numerous national and international forums. Moving on, I would request the moderators to give the opening remarks and start the session.
Thank you, Dr. Ganavi. Thanks for the introduction and thanks for the opportunity for us to present this case. I will not take much time because we have fairly large area to cover through as well. So I will set the stage for Naveen to start presenting. Just to give a brief insight, we chose this case, although not a very talked about case in among the endocrine circles. Anaplastic thyroid cancer generally is always considered a surgeon's topic or a oncology topic. And what does an endocrinologist do with anaplastic? They don't come to us. It's a general feeling many times we get, but things have changed quite a bit. What used to be a cancer with a lifespan less than a year, only 20% cross a year, have changed because of targeted therapy, where people start living more than 2 years now. Things have shown real evidence and actual patient data coming out that this cancer, which was considered deadly, is starting to have some kind of an improvement in targeted therapy based on molecular testing of the tumor tissue. So with that said, I would request the case presenter to start the presentation.
Hello, ma'am. Hello. Good evening, all. Ma'am, I have joined using Dr. Madhu Patil's Zoom link account. Can you make her admin? I can share the PPT and start.
The tech team, can you help Dr. Naveen with this?
Yeah, so ma'am, he'll be able to present now. I have made her the co-host.
Yeah. Dr. Naveen, I think you'll be able to present it now.
Yes, ma'am.
Yeah.
One minute, ma'am.
Are the slides not moving, Dr. Naveen, or?
Yes, ma'am. One. Yes, ma'am. I'll start. So, good evening, all. Myself, Naveen Kannur, endocrinology resident at Narayana Health, Bengaluru. I'm going to present a case of anaplastic thyroid cancer. Ma'am, audible?
Yeah, go on.
Yeah. So we all know that ATC accounts for just 1 to 2 percentage of all the thyroid cancers, but it is responsible for more than 50 percentage of thyroid cancer related death. As sir was saying, there is a median overall survival is only 5 to 6 months from diagnosis. With 1 year survival rate is only 20 to 35 percentage. But with the advent of BRAF targeted therapy, this 1 year survival rate has improved to 90 percentage now. She is a 68-old-year female from Bengaluru, postmenopausal with no comorbidities, no past history of thyroid disorders or surgery, no family history of thyroid-related disorders. She came with cheek complaints of rapidly enlarging right-sided neck swelling since 2 weeks and also intense headache since last 2 weeks. There was no pain in the swelling. There were no compressive symptoms like stridor, hoarseness of voice, dysphagia, dyspnea. However, she had some difficulty in breathing on lying down flat. There is no history of anhidrosis or upper eyelid dropping, no history of nausea, vomiting, visual disturbances, seizure, altered facial sensation, focal neural weakness, no history of fever. On examination, she was well built and nourished with a BMI of 31.8. Her vitals were normal. Local examination on palpation showed a mass on the right side of neck, which was 6 into 6 centimeter, hard, non-tender. Lower palpable border was palpable, not freely mobile, no movement with deglutination. However, right carotid artery was palpable. There was facial plethora even during rest, and prominent veins were visible over the swelling. So,
Just hold on, just go back there. So here you have somebody who's fairly older, coming to
yes.
you with a 2 week history of a rapidly progressive mass on the right side of the neck.
Yes.
So, what are your thoughts in the mind when you are seeing such a patient? What are the things that come to your mind when you see somebody with a large mass that is rapidly progressing in size? What are your possible differentials?
The large painless mass in this old age, I'll think about the cancers, mainly anaplastic thyroid carcinoma. It
Okay.
can also be lymphomas or secondary squamous cell carcinoma from primary from head and neck tumors. Or it can be if sometimes pre-existing nodules, there can be bleeding or infection can lead to painful swelling,
Yeah, not infection, but hemorrhage. Yeah. So
hemorrhage.
the most common differentials are typically an anaplastic transformation or a de novo anaplastic cancer. Lymphoma is an important differential, particularly in somebody with a history of lymphocytic thyroiditis. And if there's a hemorrhage around a cyst, they can also have a sudden increase or a rapidly increasing size coming in a very short duration of time. And three, as you mentioned rightly, three important physical examination findings that are very relevant when you see large masses. This is one is for Horner syndrome, other one is Pemberton sign, other one is Berry sign. All three are important, will give you some clues regarding the extent and the degree of compression of the lesion.
Yes.
What was the differential diagnosis for the headache in this patient?
Ma'am, headache can be means if you consider in cancer point of view, it can be paraneoplastic manifestation or direct metastasis. Or if you consider if it is as any infection point of view, then any infection cause headache.
So again, in your differential diagnosis, like a cervical lymphadenopathy could have been there. Again, a distant metastasis, you have like a metastatic lymph node mass that is also possible. So definitely in this case, the headache could have been a meds, it could have been an infection. So is there something that's missing in the examination? Could you have looked at the fundus and that should have been checked at this point? Again, another thing that you presented was you presented stridor as a symptom. Is it a symptom or a sign?
Stridal will be means it can be both, ma'am. Means they can
Stridor
also
is
present
typically described as a sign. It's not a symptom. Patient will not complain of stridor. That's something that you pick up on examination. Why is stridor important?
because this large mass compression of the trachea, which is the means in ATC that is the most common cause.
Intervention. So it means that you have to do something immediately. There is airway compromise.
Yes. At this point, ma'am, fundoscopy was not done. Actually, we missed that. Means it was holocranial and it improved with, it was responding to analgesics, and we didn't care much about that symptom.
So I again we'll come back to this. I don't want to spoil the rest of the, I mean, I've seen the case, so I think by fundus would have been important in this case is because of the other findings that you had. Please go ahead.
Yes. So we got the UAG neck done in our OPD. There was a large hypoechoic nodule of 6.5 into 4.8 into 3.5 centimeter arising from the right thyroid lobe. And there was the extrathyroidal extension into IJV. We can see in the second prick. And the thrombosis in IJV was present. And there was on the left side TR4 subcentimetric nodule. And the right side, right lateral lymph nodes with preserved fatty hilum were seen. However, there was one suspicious lymph node in the right level 6 region, which was 1.1 into 0.7 centimeter. So we went ahead and got the FDG PET-CT done. The findings were consistent with the UAG findings. There was a right side, right lobe, large FDG with hypodense lesion of 6.4 into 5.8 into 4.5 centimeter with very high SU max of 46.82. It was infiltrating into right IJV and right IJV thrombosis was also seen. And as we saw in the UAG, there was this right level 6 lymph node was FTGavid and size of 2.6 into 2.7 centimeter with even this was having the high SU max of 41.07. Apart from that, there are multiple sub-centimetric FTGavid soft tissue density nodules in the bilateral lung parenchyma suggestive of metastasis.
What is the mechanism of IgV thrombosis in this patient? What all are the different mechanisms that could be there?
Direct invasion and then flow, that virtuous triad will be broken, and otherwise it can be paraneoplastic manifestation due to increase in the coagulation factors.
Could also be a mechanical reason because of the flow obstruction.
Yes, ma'am.
Is
Direct invasion
why
and
is that
flow.
important? At this stage, seeing that IgV thrombosis, what does it tell us about the extent of the disease? Even before you saw the PET CT and looked for metastasis, when the ultrasound showed you an IgV thrombosis, what did it indicate to you?
So it is not means we can't get R0 resection at this point. So
Indicates locally aggressive.
local aggressive invasion is present, ma'am.
Right. Please go.
And the same day, we got the EVG guided core biopsy from the nodule, and also we sent the next generation sequencing. This core biopsy showed tumor cells had epithelial morphology, severe nuclear atypia, prominent eosinophilic nucleoli, and moderate amount of cytoplasm. There are many atypical mitosis figures. You can see one of this in the 1 minute. One of this in this small figure, and there are foci of necrosis. However, there are no normal thyroid follicles seen. IHC was done. It was diffusely positive for pan-cytokeratin, TTF1, and PAX8. It was suggestive of high-grade carcinoma favoring more of ATC.
It's important that core biopsy is done and not a usual FNAC. That's an important message again. When you have a large mass suspicions for lymphoma or for an anaplastic or a secondary, it's important to get a core because core will help us do IHCs easily. FNAC very difficult to get IHCs done. So when you get a large mass, suspicion is high, then a core biopsy because the bore of the needle is much larger, thicker tissue, cellular architecture, and the tissue architecture is better preserved for the pathologist to run the IHCs also.
So here I will just brief about the IHC markers. The
Just focus
pan-cytokeratin.
on the ATC alone. Don't waste your time on other things. Yeah, just focus
Yes.
on the ATC.
So at this stage, the staging according to AJCC was clinical staging T4B because of extrathyroidal extension into IJV, N1A due to that right level 6 lymph node involvement, and M1 due to lung metastasis. It was stage 4C due to distant metastasis. So all ATC are regardless of the clinical presentation because of their aggressiveness are classified as AJCC stage 4 only. This is the AJC staging. 4A is tumor is confined to thyroid only. 4B is there is extrathyroid extension or there are lymph node metastasis. 4C there are distance metastasis. So at this point, the NGS report was pending. We started her on palliative therapy. Initially, we gave external beam radiation therapy, 30 grays in 10 settings to thyroid primary, followed by we started on cytotoxic chemotherapy of taxane and platinum combination, weekly paclitaxel and carboplatin, which she received 3 cycles. And we had also started rivaroxaban 15 mg BD for the IJV thrombus. So this is the treatment algorithm for ATC management. First thing is will be to stage the disease and also get the BRAF mutation status. And the PET scan is important, has to be done in almost all the patients at the diagnosis only because 50% of patient will be having distance metastasis at the time of diagnosis. And apart from PET, MRI CT brain is also must because 10% will be having brain mets at the time of presentation. Coming to, as in our case, means BRAF mutated patients, if it is stage 4A, then means it is confined to thyroid, then surgery followed by chemoradiation is done. If stage 4B or 4C, we have to start the targeted therapy first and then follow up. After follow up, if it is still not resectable, we continue with the targeted therapy. After follow up, if it is down staging and it is resectable now, and if it is stage 4B, then we'll do surgery followed by chemoradiation. Then we'll switch to targeted therapy. In stage 4C, surgery and directly will start the targeted therapy. But if BRAF mutation is absent, then it depends on whether it is resectable or not resectable. If it's resectable, it will be surgery followed by chemoradiation. If it is not resectable, directly will start chemoradiation.
This, I think, has become an important, change in the management of ATC. Previously, ATC management was a little confusing. If you look at the original paper from Keith Bible, it would be, if it is resectable, surgery. If it is not resectable, do whatever else possible and things like that. Here, you are, from your staging, the next step is actually to look for BRAF. In fact, there are now methods and staining techniques by pathologists who can actually stain the tumor tissue with BRAF V600D to tell you IHC marker itself, to tell if the BRAF is positive or not. So the time delay in getting somebody to whether it is BRAF positive or not is now getting shorter and shorter. We did not have the BRAF IHC marker, so we had to do the NGS, but the expedited nature of getting the BRAF is kind of, implicit in this whole algorithm.
How long did it take for you to reach the diagnosis? The NGS took how long for the reports?
14 days, ma'am. 14 days. So in that time, she got her RT and her platinum chemotherapy. So
That
14
was how
days.
soon after the biopsy did you start the chemotherapy, sir?
So day one, so this is all important. Day one she came with symptoms. Day one she got core biopsy on PET scan and core biopsy on the same day. By day three by day two she had the ATC report, and day three or day four the therapy was begun, and we told her that they will, we will decide based on what the NGS report comes back. 14 days we got the NGS report.
That's like a wonderful timeline. I think the
It's
one.
it's very rare to get these kind because she was known to one of our doctors. That all, kind of helps because everybody coordinated the care. The daughter was very good. She kind of was with the mother, made sure that everything happens online. It's not easy, and I think this is where I think teamwork is important. Somebody calls the pathologist, calls up the radiologist, calls up the nuclear medicine. So everything has to happen very short time. This is a very bad disease otherwise. Otherwise, it'll just keep progressing very fast.
That's like, I mean, the timeline is like wonderful what you've done, and it's really amazing that you've been able to manage that and start this. And I think one thing that we need to take home about ATC is that the time is of essence. Biopsy within 24 hours and start the palliative before you can go for the actual therapy.
So we got the NGS core biopsy report. It detected three clinically important mutations. One is the BRAF V600E, third promoter mutation, and TP53 mutation. There was a very high allele frequency of T53, 93%, suggesting anaplastic transformation and aggressiveness of the disease. So just to brief about these three important mutations, BRAF V600E is the commonest mutation found in the PTC. It is less common but still present in 25 to 50% of the ETC. The valine at codon 600 is substituted by glutamate. It causes the permanently switched on BRAF and cell proliferation. When there is also accumulation of additional mutations like TERT and T53, it drives the dedifferentiation towards the ATC. As of now, BRAF is the only FDA approved targeted therapy. Third, it is uncommon in DTC, but very much common in ATC with 70% of prevalence. It is a late acquired mutation compared to BRAF. It causes dedifferentiation by reactivating telomerase. T53 mutation, it is called as a molecular hallmark of ATC, present in 50 to 80% of ATC, and it says that virtually absent in DTC. It is a very late stage molecular event, and it abolishes the normal tumor suppressor function of P53. So this is the same flowchart. Our patient was fitting in this left side of the algorithm. We proceeded accordingly. She was stage 4A because of the lung.
4C.
4C because of the lung metastasis, and also there was BRAF mutation. We started her on targeted therapy. So we started on the dabrafenib and trametinib combination targeted therapy. Dabrafenib 50 mg BD started. It was later increased to 150 mg BD, which is the standard dose, and trametinib 1 mg OD was changed to 2 mg OD. This acts at the MAPK signaling cascade, which normally gets activated only on growth factor binding, but it is constitutively active in the ATC patients. Dabrafenib inhibits the BRAF and trametinib inhibits MAK.
So, are endocrinologists allowed to prescribe this, or did you have to get this done by the oncologist?
Medical oncologist. Medical oncologists are involved. Yeah, this is a completely medical oncology. They are the one who can prescribe it.
Good.
There are many side effects. Common ones are fever and skin reaction. Some important side effects being neocutaneous squamous cell carcinoma and cardiomyopathy. Coming to endocrine wise, there are side effects like insulin resistant and hyperglycemia is very common, can present in 70% of the patient. Hyponatremia, hypophosphatemia are seen. So we got the follow-up FDG PET-CT, which is 2 months after the targeted therapy. There was reduction in the size as well as the FDG uptake in the thyroid nodule. This longest measurement reduced from 6.4 to 1.3 centimeter, and also SU max reduced from 46.8 to 29. And the meantime, there was also internal resolution of the that level 6 lymph node and lung nodules. It was suggestive of partial response. In October, she presented complaints of headache, which was for there for 2 to 3 days, and also one coincidental history of injury to forehead 1 week prior. There was no red flag signs like vomiting, giddiness, impotence, or loss of consciousness. We repeated the FDG PET-CT, but there was no interval increase in no significant change in the thyroid nodule. However, there was a non-FDG avid hyperdense focus in the left temporal bone of the temporal lobe of the brain with minor perilesional edema, likely hemorrhage.
So, is FDG PET a good test to do to look for? You were looking for meds, obviously, in this case. So, is FDG PET a good scan to do when you're looking for brain mets?
No, ma'am. MRI, contrast MRI is the
Why
best
is
one
FDG PET not a good test?
because already brain is high, means highly active, metabolically acting. You will easily miss, means we can't differentiate means in the FDG PET, ma'am.
Please go.
So same day we got the means contrast enhanced MRI brain also. It was showing a well-defined T2 hyperintense foci in the left posterolateral temporal lobe. No post contrast enhancement and very mild perilesional edema, which was more in the favor of subacute bleed, not less in the favor of metastasis. This bleed was more, we were considering more likely because of rivaroxaban. There are also flare hyperintensities with post-contrast enhancement in the sulcal spaces of left occipital, temporal, and posterior parietal lobe, which is suggestive of subacute subarachnoid hemorrhage. So we stopped the rivaroxaban, and after 1 month we repeated the MRI brain. There was interval decrease in the size and temporal evolution of the hemorrhagic component, and so we continued our targeted therapy. At this point, there was also new onset hypothyroidism, most probably because of the radiation we had given. TSH was 22. We started her on tablet levothyroxine 125 mcg. In November, we got the follow-up PET-CT that is of 8 months of targeted therapy. Uh, this time there was a interval increase in the size and FTG uptake. The size increased, longest diameter increased from 1.4 centimeter to 1.9 centimeter, and the SU max increased from 8.8 to 29.53. It was suggestive of disease progression. So in view of this progression, weekly injection pembrolizumab 200 mg was added to ongoing targeted therapy. So just to summarize about the pembrolizumab, it is a immune checkpoint inhibitor. It is a monoclonal antibody against PD-1 programmed death receptors on the T cells. Since ATC is highly express this PD ligand, PDL1, make them the ideal target of pembrolizumab. At present, it is only off-label use, not FDA approved. In BRAF V600 positive patients, it can be started as neoadjuvant triple drug therapy with dabrafenib and trametinib, or we can add later when there is no disease progression on dabrafenib and tramitinib combination therapy.
Is there an option of checking a PD-1 level expression in that core biopsy that you had? Could that have been done to sort of?
Yes, ma'am. It could have been done, but we couldn't do that one.
Okay.
But later in the biopsy, we got it done.
Okay.
Yeah. So there are many side effects, but important ones being the immune-mediated pneumonitis, colitis, hepatitis, nephritis, dermatological side effects like granulomatous panniculitis, toxic epidermal necrolysis. There are important paraneoplastic side effects like limbic encephalitis and paraneoplastic cerebral degeneration. From endocrine point of view, most common is destructive thyroiditis and causing hypothyroidism and checkpoint inhibitor associated diabetes mellitus, hypophysitis, and rarely primary adrenal insufficiency. In February 2026, he had come with fever, lower limb swelling with rashes. The rashes were erythematous and tender. We got the punch biopsy, it was showing epithelioid granulomas. We can see in the image epithelial granulomas with this giant cell, but there was no caseous necrosis. Probably it was immune related granulomatous reaction secondary to pembrolizumab. We stopped the pembrolizumab and thus responded to symptomatic treatment. In the March 2026, is last month, she was admitted with complaints of high-grade fever, irritability, multifocal myoclonic seizures. There was no focal neurological deficits or neck rigidity. We got the MRI brain. Compared to previous study, there are temporal evolution of hemorrhagic component and interval resolution of the subarachnoid hemorrhage. CSF analysis was negative. And she responded to symptomatic treatment. It was concluded that these manifestations are more likely due to primary tumor or effect of pembrolizumab. So we got after her improvement, we got the FDC PET
I
CT
mean,
done.
just hold on. Yeah, just go back. I think we were a little unsure. I would not say because till about February she was on the pembrolizumab, and March she got admitted with this fever, high grade fever, and kind of jerky response, which the neurologist termed it as myoclonic seizure. But then a complete workup by the neurologist, infectious disease team, the oncology team led us nowhere. We couldn't really establish what is the cause. uh, Empirical therapy with multiple antibiotics as well as in fact steroids also were given at some point. Then suddenly everything settled down and she became better. So we kind of think either was it because of the tumor itself, or is it because of the effect of the pembro which was given a month before. So not sure exactly what happened, but but it kind of made us push that something has to be done because things are not going the right way, as it almost now around close to a year now on the targeted therapy.
So we got the FDG PET CT repeated, and there was the interval increase in the thyroid lesion from 1.9 centimeter to 2.2 centimeter, and max also minimally increased from 29 to 31, showing the disease progression. However, the important point here was there was no extrathyroidal extension. Fat planes of the mass lesions with surrounding vessels are appearing preserved, and also no lymph nodes or organ mets were seen. So multidisciplinary team meeting and discussion with the patient attenders was done and decided to proceed with the total thyroidectomy and bilateral neck dissection. So at this point of time, clinically she was T2 because of the 2.2 centimeter nodule limited to thyroid, N0 and M0. She was downstage from 4C to 4A on targeted therapy. She underwent total thyroidectomy, central compartment clearance, and bilateral selective neck dissection on 24th of March this year. Post-operatively, we continued on levothyroxine 125 mcg. As of now, plan is to keep the TSH in euthyroid stage as because there is no role of TSS suppression in ATC as they completely lose all the TSS receptors. We got the HP report. There was a right lobe unifocal ATC of 4 into 3.5 into 1.3 centimeter. Diffuse sheets of malignant epithelial cells arranged as single cells, highly pleomorphic vesicular bizarre nuclei, prominent nucleoli, dense eosinophilic cytoplasm, and importantly, increased mitotic activity 9 per 10 hyperfield And anterior posterior both margins were involved with extrathyroidal extension to strap muscles. Lymphovascular invasion, perineural invasion was also seen. There was 1 mm focus, 1% focus of focally well differentiated papillary carcinoma. It was seen. You can see this papillary like thing in the image. Out of the 75 lymph nodes, lateral 0 of the 70 were positive, and one of the 5 central lymph node was having 1 mm micrometastasis of PTC. However, there was no extranodal extension. We also saw the post-therapy response of 40% in the form of extensive areas of hyalinization with a dense chronic inflammatory cell infiltrate and necrosis. At this stage, the her staging was T3B because of the extrathyroidal extension to staph muscles and N1A due to cervical lymph, central lymph node involvement.
So I think it's important to realize that it is not a very easy thing to operate when you have treated somebody with these targeted therapies. The surgeon will not be able to find a easy plane when they remove the thyroid gland. So it is an accepted fact that it will not be a complete R0 section as you expect. There may be some micro lesions, microscopic margin positivities expected when you are operating after somebody's targeted therapy. This is not only with dabrafenib, tremelimumab. If somebody is getting lenvatinib and then they're getting operated, also the same thing. So whenever there is a hyalinization, chronic inflammatory cell infiltrate, the plane may not be so easy for the surgeon. So that has to be also explained to the patient that this is not going to be one of the best easily removable surgery.
The indications for a thyroidectomy, like in this patient, we already know that there has been a metastatic disease. So here, I mean, you're doing it with the intent of debulking to reduce the tumor load, or
So the prognosis of ATC depends on two major factors. One is resectability of the tumor, and if you're able to, because the one that kills the patient is usually the local the site. So that is what will kill her very fast. So with the targeted therapy, we were able to at least get good resolution of her lung mets. So what hope was that if the primary tumor is completely taken out, and if she does well with that, then her prognosis will be much better. And we were not the pembrolizumab created a lot of problems for us. We didn't want to re-challenge her with the immune checkpoint. So only thing we left her with is now the dabrafenib tremelimumab. Although that pathway he showed nicely, the both the BRAF and the MEK inhibitors will work. These tumors will find ways to escape this pathway. So there will develop clones of cells which will find alternative routes of proliferation. So they will escape out of this therapy at some point. So that's why in the algorithm, once you are on the targeted therapy, if you are 4C and you have become surgically resectable, go ahead, operate. If you are still surgically unresectable, then continue the dabrafenib tremelimumab. So that's how the algorithm flows to reassess the surgical resectability at the end of as you treat them with dabra and tremelimumab. So if you are surgically resectable at some point, that gives you the best hope in terms of survival.
what was the total cost that would have the patient would have incurred over? I think
Yeah.
she's now made it to like a year and 3 months.
Yes. So dabra tremelimumab for the family per month it was about close to 2 lakhs, 2 to 2.5 lakhs.
And yeah, so it would have added to the surgery and the so we've as of now she's like on a 1.5 year survival as of
Almost close to 1.5 years now. Yeah. I mean, I think we are almost. Just can you
Yes, sir.
quickly finish up the
See, it's
last
1 year,
slides?
3 months. As of now, 1 year, 3 months.
Yeah.
Yes. So, just to give the importance about this differentiated papillary carcinoma foci, to explain the role of radioactive iodine therapy in ATC, at present there is no indication or recommendation for radioiodine in ATC. However, there is a concept of redifferentiation on targeted therapy can be explored in future, especially if the serum thyroglobulin level inappropriately elevated. Trials are ongoing. So she is planned for the adjuvant radiation to post-operative thyroid bed this week. With the biopsy, we also got the IHC for PDL1. It is positive with the tumor proportionate score of 35%. Means out of 5,000 thyroid tumor cells we analyzed, 35% cells were showing PDL1 activity, which is fairly good amount, means indicating that it will show good response to pembrolizumab. However, because of the recent these side effects, we are as of now no plan to restart the pembrolizumab. And post radiotherapy, we are planning to restart the BRAF targeted therapy. So just to summarize, we started her on targeted therapy, dabrafenib, trametinib. It downstaged her from 4C to 4A. She underwent surgery, total thyroidectomy and neck dissection. She is awaiting the adjuvant radiotherapy to thyroid vet, followed by we are going to restart the targeted therapy. So our patient who presented with metastatic stages means still alive even after 13 months after diagnosis. This survival beyond 1 year in disease with the median survival of just 5 to 6 months replace this change in the landscape of ATC management, mainly with this targeted therapy. So these are the take-home messages. Rapidly enlarging thyroid masses should always raise suspicion for ATC. FNAC or preferably core biopsy should be done on the same day when the ATC is suspected. Early molecular testing, especially for the BRAF using either IHC or NGS, is critical to guide the targeted therapy. Appropriate disease staging using both PET-CT and FDG PET and MRI brain is must in all the cases at the beginning. BRAF targeted therapy can significantly reduce the tumor burden and even downstage the disease and enable the surgery as it happened in our patient. And the main thing is multidisciplinary team care is must there.
Thank you.
Thank you. We thank our all the departments like head and neck, surgical oncology, radiation oncology, medical oncology, and nuclear medicine for their multidisciplinary support and dedicated care in the management of this case.
Do you want to give any closing remarks?
Yeah, so I think it was a beautiful case. I mean, really well managed, and it was certainly a learning case for me as well, because again, it's something that doesn't really come under our purview. And I was trying to recall the last time I've seen an anaplastic thyroid carcinoma. So it was nice to actually read and see that it has changed so much. The management has changed so much. And I think, like you said, within 24 hours to get everything done, I think that is the most important thing we need to take away. Like if you see a patient with an FNAC report that says anaplastic, or you really need to jump up and sort of move along the patient's reports. And I think, yeah. So one thing I would like to add. So what is the patient's quality of life been like while she's been going through all this for the last 1.5 years?
She's a spunky 70-year-old. So luckily no comorbid illness. An excellent. She's done well. I mean, I think the family support is also very good. Some of these things, you need to have good family support. So she's been doing well. She's doing really well, and that is what prompted the family also to take up the call for surgery. Sometimes family would say no, we will not. They can just sort of close it off, but not like they were clear that their mom she's doing well, and they wanted to take the best chances for.
That's wonderful, because again, as clinicians, we try to be a bit heroic, but
Yeah.
it's nice that the patient is also happy. So
No, at every step, I think we got them involved and told them.
because
I just,
any discussion that you read about ATC, they say prognosticate the patient about the poor prognosis, prognosticate about poor prognosis. But
yeah.
I think you've done so much, and I think without the family support and the patient getting better, I think they would not have agreed to keep going forward also. So
See,
yeah.
I think what is important, I mean, since we are all, I mean, I'm sure Siddharth is somewhere in the back, but one moment ATC comes and it is not, it's mostly 90% it will not be operable. Surgeons will take a little back seat. It'll go to the radiation, it'll go to chemo, and then kind of nobody, so somebody has to run the show fast. Things have to happen fast. And that sense of urgency, I think we endocrinologists should bring into this case. We should ensure that everything gets called, everybody get the reports processed fast, get the results ready, so that if there is a chance that somebody is amenable to targeted therapy, give them that option. Whether they are affordable, not affordable is another question. But if it is so, then it is life changing. I mean, it's a few more years of for dear one. So I think that's an important message. Thank you.
Yeah. So Dr. Ganvi, it's back to you.
Yes. Yeah.
Thank you, Dr.
Yes, sir. Thank you, Dr. Naveen. Definitely a very, very interesting case, and a very challenging case as well. And it has, as Dr. Aishwarya has also clearly stated, it was very excellently managed. So I thank the moderators, Dr. Kannan sir, for setting the context and for an excellent moderation, and Dr. Aishwarya for leading a very nice discussion. So I now request, moving on to the next session, I now request Dr. Vijay Reddy sir to introduce the moderator and the speaker for the next session.
Thank you, Dr. Ganavi. I think we had an excellent case of anaplastic thyroid carcinoma, and we saw the role of targeted therapy followed by surgery, and it was excellently managed. So next we move on to an important topic of ablation of thyroid nodules. And today we're going to look at thermal ablation of thyroid nodules. To moderate the session, we have Dr. Sachin Chitawar. Can we have the CV of Dr. Sachin? So he is Dr. Sachin Chitawar is Director, Harmony Sugar Clinic, Bhopal. He's completed DM Endocrinology from AIMS, New Delhi, and he is Associate Professor of Medicine and Endocrinology at Gandhi Medical College and Hamdia Hospital. More than 50 publications in index journals, and he is speaker at many national and international medical forums. He is recipient of A.V. Gandhi Award and Rising Star Award by IDSI Mayo Clinic. He is author of the Hindi book on for the patients. So to talk on this important topic, we have Dr. Siddhartha Chakravarti. So Dr. Siddhartha Chakravarti is Senior Consultant Endocrine Surgeon, Apollo Hospital, Jubilee Hills, Hyderabad. He has completed his MCH Endocrine Surgery from CMC Vellore. He is Executive Committee Member of Indian Association of Endocrine Surgeons. He's completed fellowship in ultrasound guided ablation for thyroid and breast tumors, China-Japan Friendship Hospital, Beijing. And he has special interest in ultrasound ablative treatment of thyroid nodules. He has conducted several ultrasound guided FNAC and ablation workshops and presented several papers in national and international conferences, more than 19 publications, and authored 2 books. Over to the moderator, Dr. Sachin Chitawar, to introduce the topic and start the session.
Thank you, Dr. Vijay Bhaskar Reddy, sir. And thank you, Dr. Ganavi, and I welcome Dr. Siddharth for the lecture. When it comes to thyroid nodules and its ablation, it is something which is still naive to our endocrine world also. Because in our clinical practice, we are hardly getting the nodules ablated, or there are modalities which I know theoretically. So I will like to hear from him what are the practical aspects and what are the challenges he faces, because we have got 3, 4 procedures, and again, there are lots of issues involved in it, and people are reluctant. As an endocrinologist also, we are sometimes not very confident to send such kind of patients for such kind of procedures. So I welcome Dr. Siddharth for a very erudite and enlightening lecture.
Good evening, everyone, and thanks ITS for giving this opportunity. Yeah, I can share my screen. Can you see my screen?
Yes, sir.
Yes. You can go to slideshow mode.
Yeah.
Yes.
It's clear? Yeah.
Yes.
So I have nothing to disclose. This is the outline of my talk, introduction, indications, stepwise demonstrations, the outcomes, complications, and the conclusion. So this ablation technique was first described by Kim and et al. In 2006, and this thermal ablations and chemical, they're all minimally invasive treatment modalities, and they can be done as outpatient procedures. They're alternative to surgery in patients with benign thyroid nodules, and you don't have any scar, and it preserves the thyroid function. So the most important thing, a clinician performed ultrasound is essential for every patient. If you don't have one, invest in it. It's the single most important tool to master non-surgical endocrine intervention. So I keep telling this to our endocrine surgery colleagues and others who have special interest in ablation procedures. It's a new technology. Whenever you have a new technology, it takes a decade at least for us to absorb and start utilizing it. And yeah, now I think it's almost nearly 20 years. So definitely it is picking up. and every patient is asking about this. So there are types of this ablation. One is a chemical ablation, which we use ethanol or polydocanol, and then thermal ablations. It is radio frequency, microwave ablation, laser, and HIFU. So I am using mostly microwave ablation, so I'll be talking about that. So indications, it is indicated in benign nodules, particularly if they have cosmetic or they have compressive symptoms. Size up to 6 centimeters we can do. And ideally, we should have at least 2 benign fine needle aspiration cytology. It is not just the benign cytology alone. It is the ultrasound also should be benign. Both if ultrasound and FNAC is benign, then we can confidently go ahead with these procedures. But if you have a ultrasound which is showing a solid nodule and that is vascular, and even though the FNAC is benign, then we should try to avoid these procedures, because minimally invasive follicular carcinoma sometimes can confuse us, and we might end up with a problem later. Then this is an ideal procedure for autonomously functioning thyroid nodules. If you have a small 2 to 3 centimeters or 4 centimeters, you can do it. Cystic lesions, yeah, only ethanol ablation is enough. It can be used in recurrent lateral compartment lymph nodes. Yeah, controversial papillary thyroid carcinoma, whether to use, but yeah, some guidelines are coming up now that if you have less than 1.5 centimeters, you can go ahead and ablate if they don't have any lymph nodes. And definitely parathyroid adenomas, because where I went in Beijing, they were ablating most of the parathyroid adenomas, and the PTH, IOPTH drops down to almost 20 or 10. So this is chemical ablation. We use ethanol 95 to 99%. It is suitable for cystic, or if you have a large mixed and cystic nodule, we stage it. The cystic component, first we do the ethanol ablation, and then it shrinks in size, and subsequently after a month or so, we do the microwave ablation. So what happens when we inject the alcohol? It causes coagulative necrosis and ischemic necrosis, and it causes the small vessel thrombosis. So if you can see here that this is a cystic nodule, a large cystic nodule. So what we do, it's important after giving a local anesthesia, you just do this entire procedure with a single prick. So you just take this Timuplex needle, and the first thing is we have to aspirate. So we put the needle inside, and we have to aspirate the entire cyst volume. So look for a non-vascular part, and under guidance, you go inside the cyst, and sometimes the contents of the cyst may be quite thick. In that case, you can inject a little bit of alcohol to dilute it, or aspirate a little bit and then inject some saline and try to dilute it. So sometimes if you aspirate the entire cyst at a time, it can start bleeding. So you have to be careful at that. So there we aspirate the cyst. So once you aspirate, we measure the volume. How much is the volume? And after measuring the volume, what we do is we wash the cavity, and then we inject about 1/3 to half of the volume that we had actually aspirated. So we inject this alcohol. So this is how, see, when we inject, you can see that hyperechogenicity that is coming. So this will cause the coagulative necrosis. So when we inject this, we keep the alcohol for 3 minutes inside, and then we reaspirate it, and we repeat this procedure for 3 times. So when we do this, it works excellent. So that's how we wait for 3 minutes then, and we repeat this process for 3 times. So this is one of our patients who had almost 4 to 5 centimeter cyst, and this is 3 months after the ablation. You can see now, earlier you are not able to see the thyroid border at all. Now you can see the entire thyroid and even the knot. This is the ablated zone. Now we'll talk about microwave ablation. So which is the one which we are doing. It's in microwave ablation, we apply a microwave. This causes the water molecules to rotate billions of times per second, and this leads to the generation of the heat. So this is the microwave antenna. So the tip is the one which gets heated up. So the temperature can go up to 60, 100 or 120 or 150 degrees also. So it is under our control, and we have to control this antenna. So if you do ablation between 60 to 100 degrees, it causes cytotoxic effect. But if you burn more than 100 degrees centigrade, then it causes carbonization. If there is carbonization, then it can't be phagocyted by the macrophages. The ultimate aim of our procedure is to decrease the volume. If you char it too much, then there won't be any volume reduction. Though you have successfully killed the entire nodule, but at the end of the day, the patient would be not satisfied. She'll still complain that I have a swelling, and that will become a big problem. So it's important not to burn more than 60 to 100 degrees centigrades. So how do you know that you are, when you're burning it, when you start seeing this echogenicity, you can see the echogenicity, that's the time when you have to stop and don't use too much power. If you use more power, more than 30 or 40, more than 40, then you start charring it. That is, then the reduction of the volume would be less. So now a little bit about the procedure. So this procedure is done under a local anesthesia. So we give a local anesthetic, and then the patient lies supine, and we stand on the back side of the head end, at the head end of the patient. So the most important thing after this is there are critical structures when we do this procedure. So how are you going to safeguard this? This is a carotid artery. That's the trachea. And then you have a esophagus here. So these structures have to be safeguarded when you are trying to burn. Sometimes the temperature can go up to 100 degrees centigrade. So you shouldn't be causing damage to the esophagus or the carotid. So what we do is we do a hydrodissection. We inject some saline, and this separates the carotid from the thyroid nodule. So separating the carotid. So here we show a short video. Now this is the carotid artery, and that's the thyroid nodule. So we come with the needle, and then we are as close to the carotid artery as possible. And you have to create a space of at least 5 millimeters to 10 millimeters. Only then can you safely ablate. So as you can see, I am creating a plane here, and my needle is anterior to the carotid. And then we have separated the carotid. Here you can see the carotid, which was very close, is you get almost a 1 centimeter. This is 1 centimeter. So you get almost a 1 centimeter of a margin. And then separating the trachea, particularly when you have a nodule which is very close. So this was a suspicious nodule which is close to the trachea. This is the anterior tracheal ring that you can see. So we come through the needle and then we inject. So that is very important. So only if you can do this proper hydrodissection, only then can you burn the entire nodule. And also when we are burning the nodule, we keep this needle then there itself. As I am burning the nodule, my assistant will be injecting saline to prevent the lateral thermal injury. Now, the other important thing is separating the esophagus. So as you can see, this tube here is the esophagus. So when we have to come, and there are several reports of esophageal injuries when you have done microwave ablation. So that's the trachea. So we come close and then gently. Now you could see the esophagus is being separated. So this procedure is as precise as surgery. So there is no margin of error also here. So you have to be extremely precise if you want to kill the entire nodule. Only then you're going to get a good result. So when you have a thyroid nodule like this, so as a surgeon, we have to plan it thoroughly. How am I going to kill it properly? So you can either start from the center or you can start from the side. But I prefer starting from the center. And then after you completed burning that area, we move to the next. We go down. This is called, so this is how we burn. So, but what we see on the ultrasound screen, if you look at this, is like this. So what you see, this part is like that. So when we put our microwave needle, you have to go to the posterior most part first. And then you start burning it. So this is called a moving shot technique. And we use the trans-ischemic approach to prevent lateral thermal injury. So this is how we systematically damage the entire nodule. So I'm going to just show you a short video of microwave ablation. So this is one of our patients. This is the nodule here. And that's the microwave probe. So we are going posteriorly. So we go almost to the posterior. And you can see here, my assistant is started injecting saline as I am buzzing it. So as I burn the nodule, you can see this gap being increased here. So what we do is this continuous hydrodissection, which I've learned in China, that's Beijing, where I did my fellowship. So very meticulously and systematically, layer by layer, under vision, you have to do it. So now when I'm close to the carotid, I don't know whether this needle is visible. There's one more needle here. Yeah, that's the needle where my assistant will inject saline. So when I'm close to the carotid, my assistant gives saline there. So these steps are very, very important. Only then can you burn the entire nodule thoroughly. So I can go almost to the edge of the nodule. And that when you see that hyperlucency, then okay, you have burned that nodule. The temperature definitely would have gone to 60 to 70. Once it crosses 50, you'll have cell lysis. So systematically, we burn the nodule like that. So this is okay. Sorry. So this is as you can see, this is the microwave probe, and you can see the 1, 2, and 3. These are the hydro dissecting needles. So when I am buzzing it, my assistant will be injecting saline in that. So now if you look at the benign nodules, what does the patient expect from us? I mean, unfortunately, these nodules won't disappear. So you have to explain to the patient that you can expect up to 75% volume reduction. And if you do it thoroughly, whatever is left over is just the scar tissue. So, but if it's a small nodule, if it's a 2 centimeter or 1 centimeter nodule, these nodules disappear with time. And the recurrence rate is less than 4.1 to 5.6%. So is one of the patients who had a 7 into 5 centimeter large colloid nodule. And we initially did a ethanol ablation for her. And 1 month later, we did a microwave ablation. So this nodule 7.5 has come down to 3.7 into 2.7 centimeters. So advantages of thyroid, your thyroid gland is retained and the function is intact, no incisions, no scars, and it's a minimally invasive, can be done as a daycare procedure. We usually keep them overnight and discharge. If it's just an ethanol ablation, we discharge in the same day. So complications, yeah, like a surgery, you can have voice change if you don't take necessary precautions. So what we do when we are ablating at the posterior most part, we talk to the patient. Hi, how are you? What's happening? Or ask him to say, and then we okay, we are close. We will be very careful there. And other reports, like you can have a hematoma or you can have brachial plexus injury. These are all very rare complications. So we follow up these patients with an ultrasound, which we do at 1, 3, 6, and 12 months. And along with that, we also do thyroid function tests. One more important thing to keep in mind, as you will see more and more patients getting this microwave ablation done, when you see this post-ablative appearance of the nodule, if the radiologist doesn't know what it is, it will look, so initially it's looked like a benign nodule. But after ablation, it looks as if it is a it's a hypoechoic nodule, which sometimes you can have this irregular on margins. It will look like a classic papillary thyroid carcinoma. For a novice radiologist, it becomes difficult, and sometimes when we also see, it looks very suspicious. So the important thing, history of the patient, that I had a microwave ablation, and the second important thing is you won't have vascularity within the nodule. So that is also very important. So it's a dead nodule, and the history of the patient has to be taken into account. Otherwise, you are going to see thyroid's 5 report, which is going to cause more complications and confusion to the patient. We have done 96 patients till now. Majority are benign and 3 are micropapillary thyroid carcinomas. So we have started a thesis topic for one of our registrar. We are doing a prospective study. We are looking at the volume reduction rate and the secondary outcomes of complications, bleeding, infections, and skin burns. Yeah, this is one of our patients who had come because we are a surgeon and we do transoral thyroidectomy. It was a benign nodule, colloid nodule, predominantly cystic with a very minor solid component. So we did ethanol ablation and a microwave ablation in the same sitting. And this is 1 month after the ablation. So you can see there is no scar. The function is preserved. What I would have done a transoral endoscopic or a robotic procedure, with this procedure, we could avoid the operation altogether. So to conclude, microwave ablation is an effective, minimally invasive treatment for benign thyroid nodules. It has a significant reduction in nodule size, improves symptoms, often with low complication rates, and shorter recovery, no scar, with preservation of thyroid function. So initially, I had gone to Turkey in 2004, but somehow I wasn't I was not happy with what. Then I went to do a fellowship in Beijing, where they do around 2,500 ablations in a year. So in a theater, they do around 10 ablations. So that's where I actually got to know the hang of it, how exactly to do. Then I understood this is as precise as I operate. So that's very important. And thank you for your patient hearing. Any doubts or any questions?
Thank you, Dr. Siddharth. It was a very enlightening, and it was the first time I have seen something like this. I just wanted to know I was just going through a paper where it talks about radio frequency ablation and laser ablative techniques. In what way these techniques course over this micro ablation techniques? And I just wanted your answer regarding that. And is it possible for an endocrinologist in future to go for such kind of training, because the kind of meticulous efforts which you have showed with respect to vascular structures and precision, is it possible for people like us who have not operated in our lifetime, and we can go for such kind of procedure in the future?
Yeah, I think as my first slide, you could see, if you want to master these procedures, non-surgical ablative procedures, you must know the ultrasound thoroughly. That is one. So you should have your own ultrasound in your clinic. Like I have my own ultrasound in the clinic. You should be able to do ultrasound guided FNACs for a 1 centimeter or a 5 millimeter thyroid nodule too. So if you are able to do these two things precisely, then definitely you can start doing ablative procedures with a training. Definitely, yes.
And what about this radio frequency ablation and laser ablative techniques? Why they are considered to be better than this microwave technique?
Yeah, I think, see, the technology is a little different for a microwave ablation. And I didn't go into the details of it because of the lack of time. So the technology is different. Radio frequency ablation we usually use for a larger nodule. Whereas for a small nodules or up to 4 centimeters, microwave ablation is quicker and faster. So you don't have exit electrodes here in radio frequency ablation. Both radio frequency and microwave ablation have almost the same results, with some saying better for radio frequency ablation over the long run. But that's not a statistically significant value. It depends. It's an operator dependent, and availability and comfortable, what you are comfortable with the technique. Laser, yeah, laser, it's not picked up so much, and even HIFU is quite expensive, and the results are not very promising as of now. So the currently microwave and radio frequency, these are the things which are popular.
Thank you. Any more questions from the audience?
Thank you, Dr. Siddharth. That was a very enlightening talk. What will be the cost for the procedure as compared to surgery? This is more cost effective or?
Yeah, I think the cost is a constraint, sir, for particularly because the antenna itself costs you around 75 to 80,000. So around 80 to 85,000 is the cost of the antenna itself, and then the machine, and so it will cost you around 1.5 lakhs or so. And sometimes, yeah, it depends from which hospital you're getting operated. Surgery can vary from 1 to 3 lakhs. So cost is a constraint, but I'm hoping in future it should come down.
So it's a disposable antenna for one patient you have to use and dispose.
Ideally, yes, it's a disposable antenna. We are supposed to discard it, but yeah, it is. You once you sterilize it and use it properly. Indian Gujarat, what we say, it comes for three patients easily. Yeah. But we at Apollo, we generally don't reuse the antenna. For every patient, it's a single use, and we try to discard it.
Thank you, Dr. Siddharth, for an excellent talk. Thank you, Dr. Sachin, for moderating this session. Next, we will go ahead with the quiz, which is a much awaited event by the DM postgraduates. So, can we have the rules for the quiz? So to participate in the quiz, click on the button. There is a attend quiz button given on the screen, which is being live streamed. So the quiz will be conducted through a platform called Slido. Preferable to use a laptop for ease of experience. And quiz will run for 5 minutes. The quiz master will display case or description of question by screen sharing a PowerPoint file. There will be 10 questions. Each question will be available only once for 30 seconds with the timer on. Kindly do not refresh the page or go back onto the page. So please click on the button, attend quiz button, and enroll for the quiz. So the quiz master for today is Dr. Merugu Chandana, who is Associate Director and Consultant Endocrinologist of Endocrinology Diabetes at AAG Hospital, Hyderabad, Telangana. She completed a DM Endocrinology from Jipmer, Pondicherry. She's member of various societies, including Endocrine Society of India, Indian Thyroid Society, and RSSDA. She has 10 publications in national and international journals, and she received multiple prizes in oral and poster presentations in various conferences. Over to you, Dr. Chandana.
Thank you so much, sir, for giving me this opportunity. I'm just
Ma'am, can we wait for more 1 or 2 minutes, ma'am?
Yeah, sure.
People have to log on.
Okay, sure.
Mumta, can you screen share the same thing?
Should I share or you are going to share the screen?
No, the QR code. Mumta, QR code.
Okay,
Yes,
sure,
QR.
sir.
You have to share the PPT, Dr. Chandana.
I'll do that, sir.
Just 1 minute. Let them
Yeah, sure.
finish
After
the
they
QR code.
finish.
Let them.
Ma'am, you can start, ma'am.
Okay, thanks. Just a minute. So is my screen visible?
Yes. Yes.
Yeah, thank you. So good evening all. Today's 10 questions are going to be pretty simple. We are going to start with the questions which were pretty much you would be knowing if you have listened to the two uh, presentations which were done just now. So I'm going to start it right now. It's pretty simple. So a 68-year-old woman, she presents with anaplastic thyroid carcinoma with lung metastasis. Molecular testing reveals BRAF V600E. And now, what is the most appropriate first-line systemic therapy? Lenvatinib monotherapy, paclitaxel and carboplatin chemotherapy, dabrafenib and trametinib combination, or immunotherapy with pembrolizumab. Your time starts now.
Next.
So the question 2, this is relevant to the second topic which we discussed today. Which modality is most commonly used for thermal ablation of thyroid nodules? Laser, microwave, radiofrequency, or ethanol?
Next one.
This is again relevant to how does radiofrequency ablation work. So which thyroid nodule characteristics? So we need to understand the ultrasound findings and this is which is associated with the highest volume reduction ratio after doing an RFA. Solid hypoechoic nodule more than 20 ml, microcystic spongiform pattern, hypervascular solid nodule, or a calcified nodule.
Next.
This is another simple question for you. A 4-year-old child was found to have a RET mutation at codon 980 on genetic screening after her father was diagnosed with MTC. She has no symptoms and her calcitonin level is normal. So what do we do next? Annual calcitonin surveillance and thyroidectomy only when calcitonin rises. Watchful waiting till age of 18 and then reassess surgical candidacy. Prophylactic thyroidectomy now. Prophylactic thyroidectomy before age 5 years with central neck dissection only if calcitonin is elevated. Which one is the correct choice?
Next.
This is another question on patient who has been on levothyroxine 100 mcg per day, but she's still complaining of symptoms of persistent fatigue and low mood, and TSH is in the normal range, but we decided clinically to add on LT3. So how do we approach this patient? First, stop LT4 entirely and start LT3 at 20 mcg once daily. Continue the same dose of LT4 and add LT3 5 mcg once daily. Reduce LT4 to 88 and add LT3 5 mcg once daily, or reduce LT4 to 50 mcg and add LT3 5 mcg twice daily.
Next one.
The next question is on a 52-year-old man who has type 2 diabetes and subclinical hypothyroidism. He demonstrates worsening glycemic control in spite of being on stable medication. So, which is the mechanism which best explains hyperglycemia in subclinical hypothyroidism? Increased GLUT4 expression in muscle, decreased hepatic gluconeogenesis, increased hepatic glucose production mediated by TSH, increased insulin secretion due to leptin stimulation.
Next one.
The seventh question, this is on a 38-year-old woman. She has newly diagnosed primary hypothyroidism. TSH is 42, creatinine is 1.2, EGFR 75, CPK is elevated. So which one of the following tests explains her renal dysfunction? Increased renal prostaglandin synthesis, which is leading to hyperfiltration, reduced renal blood flow due to decreased cardiac output and increased systemic vascular resistance, direct immune-mediated glomerular injury causing nephron loss, increased tubular secretion of creatinine due to T3 deficiency.
Next.
So this is one interesting question. A thyroid ultrasound, it shows multiple well-defined hypoechoic areas throughout the gland. There's no internal vascularity within these areas. The surrounding echogenic fibrotic bands are seen. Overall, the gland is enlarged and heterogeneous. What do we do next? FNAC of all the hypoechoic areas or FNAC of the largest lesion based on the Thyroid's classification. No FNAC, immediate surgery because the patient has a diffuse infiltrative disease.
Next.
42-year-old woman, she has a BMI of 36, TSH 6.8, high normal FT4, high normal FT3, normal FT4, anti-TPO negative. She's totally asymptomatic. What is the most appropriate interpretation? Subclinical hypothyroidism, thyroid hormone resistance syndrome, adaptive hyperthyroidopenia, early autoimmune thyroiditis.
Next one.
So the last question, a researcher blocks enzyme deiodinase type 1 in a healthy volunteer. So what do you see in this patient? Increased T3 and decreased reverse T3, decreased T4 and increased TSH, or increased reverse T3, decreased serum T3, increased TSH, decreased T4 and T3 equally. This goes back to your physiology.
Okay, ma'am, done. Thank you.
Done. Thank you. So while the tech team checks out who's standing where, shall we discuss the answers, sir? Okay, I'm going to share the screen again. Just a minute. So we'll look at the answers. I hope most of you got them right. So the answers to the questions, The first question is pretty straightforward. It's direct from the case presentation, which was given by Dr. Naveen earlier. So this patient needs to be treated on daftravimab and trametinib. So this combination is a current FDA approved standard of care, and it has shown that overall survival at 2 years, if combined along with surgery, there's almost 80% survival rate in this population. Why not the others? Lenvatinib has a limited efficacy. It's not first line. Chemotherapy we usually do when there's no targeted option. We have the BRAF mutation here. We can look at the targeted option. So this is not a treatment here. Immunotherapy, its role is emerging right now, but again, it's not the first line. The first line therapy is the daftravimab. The second question, which modality is most commonly used? Although sir has discussed in detail about microwave ablation, presently it's the radiofrequency ablation which is the bulk which is being done. Microwave ablation has also is second best, is like most commonly done, second most commonly done. But as of now, radiofrequency ablation is the most common done. The third question, which thyroid nodule is associated with the highest VRR? The microcystic spongiform pattern. This has the highest mean VRR of about 76%, whereas with the solid nodules, it's usually around 67%. So if we see a microcystic spongiform, we can expect a much better response with thermal ablation in these patients. I hope most of you got it right. The RET mutation at codon 918. So for the patient, we do a prophylactic thyroidectomy. So we know this patient, we would be having a highly aggressive MTC, most likely. So a thyroidectomy has to be done as early as possible. So we have diagnosed in this 4-year-old patient, so we need to do a thyroidectomy and follow up the patient. This question about combining LT4 and LT3, what we need to do, I'm just going to this, which is from our journal, the Thyroid Research and Practice. The recommendation says that whenever we are initiating LT3, we need to reduce the LT4 by about 1/18th and add on LT4. So here in this patient who was already on, we start about 1/17th of the dose of LT4. We start that dose of LT3 and then we reduce the LT4 by about 3 times the dose which we are giving. So 3 times of LT3 5 mg is 15. So we reduce 100 by 15 to make it around 85, which is 88. And we add on 5 mcg of LT3. This question where we are looking at type 2 diabetes and subclinical hypothyroidism, the reason for worsening is usually the TSH causes increased hepatic glucose production. The other three ways it acts is it induces insulin resistance at the muscle and the fat cells, and also increased leptin secretion happens, which stimulates hepatic gluconeogenesis. And the renal dysfunction which happens in patients who have thyroid hypothyroidism and which is reversible is usually because the reduced renal blood flow because of decreased cardiac output and increased serum vascular resistance. This is one which is causing the impaired renal parameters, which can be reversed once the thyroxine replacement is appropriate. And this is an interesting question which is based on ultrasound findings. In this patient, we do not do an FNAC. What is the most likely cause here? The most likely cause is a chronic lymphocytic thyroiditis. This has multiple ultrasound findings like the white knight, the Graf height, and the Swiss cheese. So the pattern which we're talking right now was the Swiss cheese pattern, where there are multiple hypoechoic areas with marked fibrosis. The most important thing here we need to understand is the vascularity, which is not there in these nodules. So this distinguishes it from the normal tissue or the tissue which is at an increased risk of malignancy. The question 9, these options look pretty close by. But the answer here is the adaptive hyperthyroidopeninemia. If we look at this, because of increased weight, obesity, leptin levels increase. Leptin levels cause increased conversion from pro-TRH to TRH, which increases the TSH, and it also increases the dehydrogenase activity, which increases the free T3. Let's look at the question 10. Here, this is something which is a little more deeper. If the type 1 dehydrogenase is blocked, there is increased reverse T3 and decreased serum T3. Sorry, increase. So why this happens is because normally what it does, it converts the reverse T3 back to T2. That is, the clearance of reverse T3 happens because of dehydrogenase 1. And also, it is involved in the peripheral T4 to T3 conversion. So this kind of mirrors the low T3 syndrome, which happens in critical illness, because in that situation, the D1 activity is usually suppressed. So the D2 activity partially compensates for the local T3, but it cannot fully restore the serum T3. So that's it. Thank you. Do we have the answers? Sorry, do we have the winners from the quiz?
Yes, ma'am. Sharing the screen.
Yeah, please do. I'll stop my share. After that, we'll discuss about the practitioner's quiz also, which was put online earlier. So we have the winners. Number 1 is Dr. Skar. Number 2, Dr. Stravani. And number 3, Dr. Spee. I think there are a lot of short forms here. Hope you can decipher their names and give them the certificates. Thank you. A job well done. Shall I go ahead and discuss the practitioner's quiz now?
Yes.
Yeah, sure. So this was the practitioner's quiz, which was shared earlier online. Pretty basic level, but something very relevant to us in our practical day-to-day practice. So a 35-year-old with TSH 8.5, normal FT4, anti-TPO positive, LDL 190. So which is the strongest indication to treat? So here if you're seeing the patient is 35-year-old, TSH is slightly elevated, subclinical hypothyroidism, anti-TPO positive. So usually what we say is anti-TPO positive subclinical hypothyroidism we'll treat. No, here actually the main indication is the dyslipidemia. So this is from our thyroid research and practice article from May 2024. So here we can see that dyslipidemia and subclinical hypothyroidism is often reversible with LT4 therapy and the cardiovascular risk factors are reduced. So treating this is very important. Anti-TPO positivity predicts the progression and we usually consider treating those patients, but this is not an immediate treatment trigger. If the patient has dyslipidemia, that means the patient needs to be started on treatment. The second question, which factor most strongly predicts malignancy in thyroid nodules? This is the ultrasound findings which we are looking at, and which is the microcalcifications. The size, if in ultrasound, even if the size is more than 2 centimeters, that can be benign also. So microcalcifications are suggesting that it could be a TERADS 5 feature. The risk for malignancy is pretty high. They represent the psammoma bodies. So if a patient has microcalcifications on ultrasound findings, we should immediately consider the patient for FNAC. The next question is, a pregnant woman, 10 weeks, has TSH 3.8, anti-TPO positive. What is the best step? This is very relevant in practice because most of us miss treating this subclinical. We say this is normal TSH. Some of us think this is normal TSH. Why do we need to treat? But in pregnancy, the values are different. What we need to target is different. So in this patient, we need to start treatment. So first trimester, the upper limit target is less than 2.5. And in the second and third trimester, it is less than 4. And if the patient has anti-TPO positivity, it's a very strong indication for treatment with LT4. Best test to differentiate Graves' disease versus thyroiditis, TSH, anti-TPO antibody, and FNAC. No, these are not the most important tests. The most important test is a thyroid scintigraphy. Sometimes we do a TSH receptor antibodies also in case scintigraphy is not available. This radioiodine uptake test is a gold standard which differentiates between the destructive thyroiditis from Graves. Usually in Graves, the uptake is very high, almost around 30 to 40%. Whereas in thyroiditis, the uptake is very low because the hormone is released from the destroyed follicles. It's not being synthesized in the thyroid gland. Anti-TPO is non-specific. Please do not do in case of hyperthyroid patients. There's no relevance in doing an anti-TPO. The next question was on patient was on levothyroxine. The TSH was pretty fluctuating in spite of the patient being adherent. So what could be the most likely cause? Whether can it be high iodine intake or drug interactions affecting the absorption, pituitary disease, or thyroid hormone resistance? First thing we need to see is what else is the patient taking, because usually the patient on thyroid hormone replacement is on multiple other treatments also. Most commonly it's the PPIs which they take. Sometimes they take both the tablets together. So this absorption can be impaired by PPIs, calcium intake, iron intake, antacids, cholestyramine, sucralfate, and sometimes foods also. Even coffee can affect it. So it's always advised that the tablet has to be taken on empty stomach, and at least 30 minutes to 60 minutes has to be given, a gap of 30 minutes before they take coffee or any other food. So most of the patients think that PPI has to be taken empty stomach, thyroid hormone tablet has to be taken an empty stomach. Let's combine them together. That can impair the absorption. And this is another pretty simple question, which is the most common location for ectopic thyroid tissue? The lingual region. There could be a small nodule at the base of the tongue, which could be the actual thyroid hormone producing part of the ectopic tissue. So that needs to be carefully assessed. So we usually do a conservative management, and the lingual thyroid is the most common site, which accounts for about 90%. Most of the time, it could be the only functional thyroid tissue. And if we consider ablating it, then the patient might develop hypothyroidism. So we usually do not consider ablating unless the patient has some concern because of it. And gut microbiota, yes, it can affect thyroid function. How does it affect? It affects by altering micronutrient absorption. It does not involve in the other parameters. It's usually the micronutrients which are needed, like iodine, selenium, zinc, iron. These are all essential for thyroid hormone synthesis. The gut microbiome can regulate their absorption. Usually the selenium absorption can get impaired, that can impair the dehydrogenase activity, cause lower T3 conversion. Also, there can be increased LT4 metabolism, and also the intestinal transition can be affected because of gut microbiota, and if the patient is on replacement, that absorption can get reduced. And this is another very important question. Somebody has got some ultrasound done of the neck and they find a nodule which is about 5 mm, which is less than 10 mm. What do we do? Do not go for an FNAC, do not go for any surgery or any other further test. Just make sure you observe the patient again after 6 months to 1 year. So the small thyroid nodules, we usually ask them to review again after 6 months, because even if the patient had a papillary microcarcinoma, which is extremely indolent, the progression is very slow, less than 1%, metastasis even lower. So we do not rush and do anything else. We follow up the patient and see the patient again at 6 months or 12 months. The next question, a thyrotoxic patient, he presents with acute quadriparesis and hyperkalemia. So what is the most likely diagnosis? That here the diagnosis is muscle breakdown with potassium release. This is a very interesting case because what we normally associate quadriparesis and thyrotoxicosis is with hypokalemia. So this patient had hyperkalemia. This is one case report which is published in Thyroid Research and Practice. So here this happened because of rhabdomyolysis, the thyrotoxic myopathy, and the CK is markedly elevated. So this is different from the thyrotoxic paralytic paralysis, and this needs to be managed in a different way. So the next question is, a patient with MTC has calcitonin pretty elevated 18,000 and RET exon 11 mutation. What is the next critical pre-op step? So we know the patient has MCT, the patient has a RET mutation. What do we do next? We first screen the patient for pheochromocytoma before doing anything else. Because any patient who has a RET mutation, especially the exon 10, 11, 13 to 16, most likely they have MEN2A or MEN2B, and pheochromocytoma is seen in about 40 to 50% of these patients. So we need to rule out pheo in these patients because undiagnosed pheo increases the surgical risk. The patient might develop a crisis on table and might turn out fatal also. So pre-op screening for metanephrines, look for urine catecholamines, do an adrenal MRI if positive, manage the pheochromocytoma before taking up the patient for surgery. So that's it. Thank you all for patient listening. I hope it was informative. Thank you, Vijay sir.
Can we have the results of the practitioners quiz?
So we have the results, winners of the quiz conducted for practitioners. Number 1 is Dr. Mohammad Ghosh. Very good. Number 2, Dr. Aisha. And number 3, we have Dr. Sudha. Thank you.
Thank you, Dr. Chandana, for an excellent quiz. I think it was a lot of learning experience. Over to Dr. Ghana.
Thank you. Thank you, ma'am. This was definitely a very compelling quiz and also discussing the answers as well. So as we conclude today's session, so before we conclude, so please reach out to us, the quiz winners, especially if you haven't received your certificate of appreciation. You can send an email to either Dr. Pramila Kalra, to myself, or to the tech team. The email IDs have been displayed. So you can, those who have won the quiz in the previous sessions and have not received the certificate can mail us on the following email IDs. So another short announcement before we proceed further, those who are interested to submit the journal to the flagship journal, that is the Thyroid Research and Practice, can do so by scanning the QR code displayed on the screen. And those who are interested also to become a reviewer for the Thyroid Research and Practice can scan this QR code displayed, and it will help you sign up as a reviewer. So as we conclude today's session, I'd like to invite Dr. Pramila Madam to share the closing remarks.
Thanks, Dr. Gandhi. I think we had an excellent discussion today. We had an excellent quiz to end with, and to start with also, we started off with discussion on anaplastic thyroid cancer. Dr. Naveen presented it, and Dr. Subramaniam and Dr. Aishwarya nicely moderated it. And we had an excellent talk on the thermal ablation of thyroid nodules by Dr. Siddharth, and it was moderated well by Dr. Sachin. And the quiz was also the highlight of the day for today. I think Dr. Chandana did a very nice job, and we had a lot of learnings, as Dr. Vijay Bhaskar said, that all of us had a lot of learnings from the quiz. So, and we also congratulate the students who have won the quiz. And it's nice that so many students are participating. And as Dr. Ganvi already told, that if any one of you who have won these quiz competitions in the past and have not received the certificates till now, please mail to us. We are displaying the mail ID, and we will be sending your certificates in a short while. Also, please submit your articles to Thyroid Research and Practice. This is the Journal of the Indian Thyroid Society, and this is definitely going to be, we are going to get it indexed very soon also. So please submit your articles to the Thyroid Research and Practice Journal, which is a journal of the Indian Thyroid Society. And I then hand it back to Dr. Ganvi to tell the proceedings for the next thyroid clinics, because it is going to be a special thyroid clinic. So she'll be just telling you about that.
So our next thyroid clinic session is scheduled for 25th May, which is also the World Thyroid Day. So we request everyone to join us for the same. So thank you all for joining. To conclude, and we wish to host you the next time on the 25th of May. Thank you. Good night, everyone.
Good night. Good night, everyone.
Good night.
तस्य भासय सर्वमिदं विभाति